So thank you, Graham, and the organisers for this opportunity to present to you today. So what I'd like to convince you all of today is that not necessarily to reach for your knife in the immediate management of these patients. It needs a bit of a workup. Surgery is appropriate in some of them, but by no means all of them. I just need to start off with a declaration that I am the principal investigator on a trial which I will mention today, which is funded by a pharmaceutical company. So, as many of you are probably already aware, there are three types of neuroendocrine tumour which have different etiologies. The commonest by far are the type 1 gastric neuroendocrine tumours, which arise on a background of chronic autoimmune atrophic gastritis and usually pernicious anemia. Type 2 gastric neuroendocrine tumours form less than 10% and arise in the context of Zollinger-Ellison syndrome, but not the sporadic form, usually the ones that are associated with MEN1. Type 3 gastric neuroendocrine tumours are not associated with a raised gastrin, unlike the others, form about 15–20%, and these are raised sporadically and are a different type of tumour again. So just to revise a little bit of basic gastrin physiology from medical school, when you eat a meal, the G cells, which are located predominantly in the antrum of your stomach, secrete the hormone gastrin. This binds to the ECL cells, which are located predominantly in the corpus of the stomach. These secrete histamine, which binds to the parietal cells to cause acid secretion. And obviously these two areas are the targets of H2 receptor antagonists and PPIs that we use to suppress acid production. So in type 1 gastric neuroendocrine tumours, this is what happens. So in the context of an autoimmune atrophic gastritis, there is a loss of parietal cells in the stomach, leading to an inability to produce gastric acid. The consequent hypo or achlorhydria in many cases leads to an increase in the number of gastrin G cells in the antrum of the stomach. They secrete gastrin, which can be detected in the bloodstream. The gastrin acts on the ECL cells, but because these are not able to stimulate acid production, the ECL cells increase in number, undergo hyperplasia, and in some patients this progresses to a frank neuroendocrine tumour. So actually, the first thing you need to do with these patients is to establish the cause of the tumour and to stage it. And this is relatively straightforward to do. It doesn't require very many investigations. You essentially need to measure a fasting serum gastrin concentration. Interpretation may be a bit difficult, particularly if a patient's on a PPI. You need to measure the pH of the gastric juice, and you need to look for evidence of the associated conditions that I've already mentioned. As with any other tumour, you also need to stage the tumour with investigations such as CT scan and radionuclide scans. Endoscopic ultrasounds needed in some patients, but by no means everybody. And the size of tumour is quite an indicator here. So the smaller tumours are obviously much less likely to have metastasized. And type 1 tumours measuring less than a centimetre in size virtually never metastasize. So this is an algorithm for the assessment of such patients, and it's relatively straightforward. So if you find a neuroendocrine tumour in the stomach, which is confirmed histologically, you need to measure a serum gastrin concentration and assess the pH of gastric juice while off PPI or H2 receptor antagonist. In most patients with a type 1 gastric neuroendocrine tumour, the gastric juice will be pH 7, achlorhydric, whereas in Zollinger-Ellison syndrome, you're still going to have a very acidic gastric juice. So we're not usually looking at subtleties here. It's either pH 1 or 7. We rarely find it anywhere in the middle. If the gastrin level is normal, it's more likely to be a sporadic type 3 gastric neuroendocrine tumour, but you need to check that it's not a type 1 which is masquerading with just a slightly low gastrin concentration, or that the gastrin hasn't been misanalyzed because the sample's been warmed up or something like that. So it's probably worth checking some gastric corpus histology to make sure there's no parietal cell loss. And this table summarizes the characteristics of the three types of gastric neuroendocrine tumour, as I've just mentioned. So we've already discussed the etiology of the three types and their relative frequencies. The type 1 and type 2 tumours normally arise in the fundus of the stomach, and they're normally quite small and multiple, so characteristically less than a centimetre in size, and there may be 10 or 20 of these polyps if you look hard enough. The Type 3 gastric neuroendocrine tumours can arise anywhere in the stomach, and usually at presentation they're somewhat larger, and characteristically they're single. We've already discussed the association with gastrin concentration in the blood and gastric acid output. The prognosis is also very different for these three tumour types, which is one of the reasons why we need to establish the cause, in that type 1 gastric neuroendocrine tumours usually have a very good prognosis. The type 2, the prognosis is associated with that of the underlying MEN1, and the type 3 have a much poorer prognosis. These should essentially be treated like gastric adenocarcinoma and treated with aggressive surgery. So I'd like to now proceed and discuss a few typical clinical cases. And this is the most common scenario that you're likely to see. And I've got several patients like this in my clinic. So a 65-year-old lady who was referred by a GP for an open access gastroscopy because of anemia. During this investigation, some gastric polyps were found, and these were found to be gastric neuroendocrine tumours on biopsy, but no other biopsies were taken at the initial endoscopy. On referral, we did some subsequent investigations, and we found evidence of vitamin B12 deficiency, positive gastric parietal cell antibodies, marked serum hypergastrinemia, and in this case, and which is typical in these patients, a normal serum chromogranin concentration. This is an endoscopic image of the tumours. So in the corpus of the stomach, you can see some attenuated folds here from the underlying atrophy. You've got a polyp, which was about 1 centimetre in size. If you want to measure them, just open up some biopsy forceps. They usually measure about 7 or 8 millimetres. So this was just larger than some open biopsy forceps. But you can see there are a number of other little associated nodules in the stomach. So she had 5 or 6 nodules, the largest 1 centimetre in size. You can suck out gastric juice very easily. If any of you want to know how to do it, just put on a polyp trap and suck it out. It comes out very easily. You can test it with just some pH strips. Gastric pH was 7. Took some biopsies of the lesion. They showed typical bland neuroendocrine tumours, and on immunohistochemistry with a neuroendocrine marker such as chromogranin A, they're positive. We also want to do a proliferation index, a Ki67 index. This was less than 1%, so this is a low-grade gastric neuroendocrine tumour. I would also suggest that you would like to take biopsies of the surrounding normal unaffected mucosa, and this is what it showed in this case, and which is typical. We've got an atrophic gastritis, so there are no parietal cells virtually in this section. In this gland here, you can see some white areas. Those are goblet cells, so you've got intestinal metaplasia, and there is some foveolar hyperplasia here. If you stain this background mucosa with neuroendocrine markers, in this time I've chosen synaptophysin, it shows often linear, as shown there, or micronodular ECL cell hyperplasia. So even in the unaffected mucosa, there is an increase in ECL cell density, but not frank tumor development. If you take biopsy of the antrum and perform immunohistochemistry for gastrin, these are brown cells that show up. So normally there are about 2 or 3 maybe gastrin cells per antral gland. You can see in these glands there is a marked increase in the number of G cells, and this is what causes the hypergastrinemia that we found in this patient. She underwent some staging investigations, and as is typical in this patient group, they were normal. So a CT scan was negative, no evidence of metastatic spread, and an octreotide scan was normal. So the diagnosis following relatively straightforward investigations is relatively easy to make. She had multiple type 1 gastric neuroendocrine tumours, the largest measuring 1 centimetre in size. There was no metastatic spread, and she had some associated pernicious anemia, which obviously needed replacement therapy. So I would suggest that these are the potential management options in this lady. You could say these tumours are small, they're not giving any symptoms, why don't we do nothing at all and maybe look again in a year and see if they've grown. You could say, well, these polyps look nice and juicy and I'm an interventional endoscopist and I can't resist removing them, so let's undergo an endoscopic polypectomy. You might say, well, neuroendocrine tumours respond to somatostatin analogues, so why don't we give a long-acting analogue and see if it regresses. You could be wanting to sharpen your knife and you've recently been practicing your laparoscopic techniques and want to undergo an antrectomy to remove the gastrin drive that may be causing these tumors to develop. Or you may actually be particularly eager to do a total gastrectomy. Finally, if you are aware of clinical trials in this area, you might want to enroll a patient because it's not actually clear what to do, and each of those 6 options is, to some degree, reasonable. So what I'd like to do is just go through most of those, discussing the evidence for them and why they may or may not be a good idea in this particular patient. So why would you want to undergo a polypectomy? Well, it's relatively straightforward to do. It's distinctly feasible in the stomach. The gastric wall is relatively thick. The chances of perforation are relatively low. It's well tolerated in most people. And undergoing polypectomy of 2 or 3 tumors in the stomach is relatively straightforward to do. If you've got more than 5 or 6 tumors, it's a bit difficult to do in a single sitting. The main problem here is that you remove the tumor, but you don't actually remove the underlying problem, the hypergastrinemia. And so almost always the tumors will recur at some point. And so if you do undergo endoscopic polypectomy, it's mandatory to perform regular endoscopic surveillance to see if the tumors are recurring. But for small lesions that are few in number, this is a distinct possibility and one that should be considered in this patient. What about long-acting somatostatin analogs? Well, the total evidence in the world literature is one series of 5 patients published from Norway, but this has led to 3 publications because they published, when they finished the study, they published a year after and they published 5 years after. And the papers are interesting to read. So at 1 year, on completion of a year's treatment with sandostatin LAR, there was about 50% regression in the number of polyps. A year later, much the same was found. They hadn't recurred. However, when they looked at 5 years of follow-up, the tumors had all recurred, and some of them had got much more aggressive. One had metastasized, and one had become more malignant in appearance. One conclusion that you could draw from this is that somatostatin analogs are not a treatment option, and they certainly aren't for just 1 year of therapy. And what could be considered is that you give this long term, but there is no trial evidence or even case series evidence to support that, and I therefore think it would be a little bit tricky to embark on as a sole treatment modality with current evidence. What about an antrectomy? So an antrectomy can be done laparoscopically. Here's a very nice operation. You remove the antrum of the stomach with the G-cell drive. In our patients, typically, it leads to resolution of hypergastrinemia within about 5 or 6 hours of the operation. So it removes the gastrin drive completely. And the theory is that in many patients with gastric neuroendocrine tumors, the polyps will melt away. And that indeed happens in many subjects. However, that relies on the premise that the tumors are still growing in response to that gastrin drive. But as tumors develop, they will acquire additional mutations and develop the ability to grow autonomously and therefore not be gastrin dependent. So we've been recently looking at the role of a test called the octreotide suppression test to see if we can predict whether tumors are still gastrin responsive or not, and therefore whether or not they're likely to respond to antrectomy. This is what an octreotide suppression test involves. You perform an endoscopy at time 0, infuse octreotide intravenously for 72 hours, monitor the the serum gastrin concentration. They can't fast the whole time. And then after 72 hours, perform a second endoscopy with a second set of biopsies. We measure the serum gastrin, as I've said, and the typical response is a marked reduction within an hour or 2 and suppression of the hypergastrinemia, not complete. Normal serum gastrin concentration is about 40 picomolar, so it's still quite high, but much less than when it started. And then we analyze the abundance of a specific enzyme that's expressed by ECL cells called histidine decarboxylase, or HDC. Here I've shown a northern blot, but we now actually do this usually by real-time PCR, but the northern blot is a nicer image. So what we've got here is corpus and nodule pre-octreotide infusion. The darkness of the bands implies the amount of this enzyme present, and as you would expect, in the polyps, there's more of it than in the corpus. After infusion of octreotide, there is a reduction in the amount of this enzyme at both sites. So this is what we would call a positive octreotide suppression test, suppression of serum gastrin and suppression of expression of the HDC enzyme following infusion. And we've taken this as an indicator that antrectomy might be appropriate. And this we would normally perform in patients who've got multiple tumors, probably a bit larger than 1 centimeter in size, but without any metastatic spread. The ones that endoscopic removal is not possible. So we've now gone and done this in 5 patients. Well, we've actually done the octreotide suppression test in 6, but 5 of them have gone on to have an antrectomy. All 5 patients showed a reduction in serum gastrin during the octreotide infusion, and all showed a marked reduction in HDC expression following octreotide infusion, more marked in the polyp than the corpus. So all of them had a positive octreotide suppression test. All patients have now undergone an antrectomy. The first was done open by Graham here. The last 4 were done laparoscopically by my colleague Milind Shrotri. In 4 of the 5 patients, all the polyps have regressed. Within about a year, the polyps have regressed and they've not recurred. And in all patients, they've had regression of hypergastrinemia following surgery. However, 1 patient, despite a positive octreotide suppression test, had a persistent tumor at 2 years and has subsequently undergone a completion subtotal gastrectomy. And there was a residual 15 millimeter gastric neuroendocrine tumor in the resection specimen. So unfortunately, although we thought it was a good test, this does not reliably predict response to antrectomy following in patients with type 1 gastric neuroendocrine tumors. So what we actually need is an assessment in response to a gastrin antagonist, which is what the antrectomy does, rather than to octreotide, which, although it suppresses serum gastrin, also has other effects. And that's what we've been doing recently. So in collaboration with Trio Medicines, we've been analysing the effects of a gastrin CCK2 receptor antagonist, which is orally bioavailable. To date, we've treated 8 patients with type 1 gastric neuroendocrine tumours, and we've treated them all for 3 months. In all patients, we've seen a response. This is an open-label trial, but we've measured a 40% reduction in either tumour multiplicity or size, and in all the patients, there's been a reduction in serum chromogranin A. Now, the baseline serum chromogranin A in most of these patients is not particularly high, but nonetheless, it's come down in all of them, suggesting that the drug is active. It's been very well tolerated, no significant side effects in any patient. And what we're currently doing is we've got ethical and MHRA approval to carry on treatment in these 8 patients for a subsequent 12 months. And it'll be interesting to see whether the tumours actually regress further in those subjects. So, going back to our initial slide, what should we do in this lady? Endoscopic surveillance at 1 year, that would not be entirely unreasonable. Endoscopic polypectomy might well, with the current evidence, being my first management decision in this lady. Long-acting somatostatin analog, no evidence really at the moment. Antrectomy could be considered, but her tumours are really not big enough or multiple enough to warrant that really at this stage. Total gastrectomy, please don't do it. She's going to be a gastric cripple, and it won't do her any good whatsoever. Enroll in a clinical trial, yes, if you've got suitable patients, please send them along. We're the only centre recruiting at the moment to this trial, but if we get nice results, it may well be extended further. Just to show that type 1 gastric neuroendocrine tumours are not always this indolent, and sometimes you do have to do something more aggressive about them. This is another chap that we managed last year, 60-year-old male, again found to have gastric polyps during investigation of anemia. And again, some baseline investigation suggesting that these were type 1, so vitamin B12 deficiency, hypergastrinemia, but also note on this occasion a markedly elevated serum chromogranin A. But as you'll see here, these are completely different beasts. These are much bigger tumours. There are 2 large tumours. This is with the scope retroflexed. Large tumour in the fundus, measuring 5 centimetres, smaller one there, which measured 3 centimetres. Ki67 index was still low, and the background mucosa was still flat and atrophic. But on this occasion, the staging investigations were a little bit different. So on the CT scan, you could see the 2 polyps quite nicely within the stomach, but there was no evidence of metastatic spread in the liver. And on octreotide scan, you can see a hot spot there in the fundus, top of the stomach, which was from these tumours. He's the only patient out of a series of about 60 or 70 that I'm looking after at the moment who's needed a total gastrectomy. But I do think that in this single case, it was the right operation. He had 2 large lesions with background atrophic gastritis. The Ki-67 index on the resection specimen was about the same, 2%, but he had 2 positive lymph nodes. He's currently 12 months post-op. He's doing quite nicely, but obviously there is a chance of recurrence because of his lymph node involvement. So gastrectomy is sometimes needed, but often is a little bit too aggressive, I would suggest. So I'd just like to conclude very briefly just by talking about the other 2 types very quickly. Type 2 gastric neuroendocrine tumours, as we said, arise in the setting of Zollinger-Ellison syndrome when it's associated with MEN1. In sporadic Zollinger-Ellison syndrome, the incidence is much, much lower. This is a case that we treated a little while ago. 35-year-old male presented with hematemesis, underwent an endoscopy, was found to have some small gastric polyps. On taking a further history, he'd had some dyspepsia and diarrhea for 6 months before that, and I think it was his father had had peptic ulceration. He had hypergastrinemia, a slightly raised serum chromogranin A, but also importantly hypercalcemia and a raised PTH. So he had hyperparathyroidism, primary hyperparathyroidism due to his MEN1, and he also had evidence of Zollinger-Ellison syndrome. Now, the polyps here are subtle, very small lesions, and unless you look carefully, you won't necessarily see these, but the endoscopist noted them, and the recent BSG guidelines on gastric polyps, if for any of you who are endoscopists, suggests that we should biopsy all polyps. I've had a lot of flack for that, because lots of fundic cystic gland polyps are being biopsied, but in certain occasions, and this is one of the reasons for it, it shows things that you're not expecting. So these turned out to be gastric neuroendocrine tumours. On further imaging, he had a lymph node adjacent to the head of his pancreas, which showed up on EUS and was positive by octreotide scan. So this sort of patient should have a surgical treatment to remove his gastrinoma. In the setting of MEN1, most of the gastrinomas are actually located in the duodenal wall rather than the head of the pancreas, whereas sporadic gastrinomas more commonly arise in the pancreas. So if it's not immediately obvious where the tumour is, the recommendation is that you have a duodenotomy to further explore for the possibility of tumours. There can also be multiple gastrinomas in the duodenum. So this chap had a Whipple's resection and has done very nicely. There are some case reports of endoscopic mucosal resection of the gastric neuroendocrine tumours, but they don't really cause any major problem in these patients. They're a reflection of other pathology going on rather than being the problem themselves. And there are some case reports of the use of somatostatin analogues. There's a trial of YF476 being conducted in these patients too in the US. And very finally, type 3 gastric neuroendocrine tumours. These are a completely different type of thing altogether. They're not related to hypergastrinemia. They're usually solitary lesions and larger at diagnosis. They usually occur in older patients. Metastasis is much commoner and the prognosis is much worse. So if you essentially manage them as you would think of managing a gastric carcinoma, you probably won't be going far wrong. They may, depending on the proliferative index, they may or may not be chemoresponsive. Many of them have a relatively low Ki-67 index. But in terms of their surgical options, it is more like a gastric adenocarcinoma. This is what I've just said there. If the tumour is metastatic, there are a number of treatment options, one of which might be chemotherapy, but the other things that you will hear about later, perhaps in a discussion, might be suitable here. So if I could leave you with a few relatively straightforward take-home messages. Gastric neuroendocrine tumours are relatively straightforward if people understand their etiology and investigate them carefully. What we want to know is the size and site of the tumours, whether they've metastasized, but importantly, what the underlying cause is. Are they type 1, 2, or 3 because they're managed completely differently? There are several management options which should be discussed ideally with a neuroendocrine tumour multidisciplinary team who's familiar with managing these patients. There is often not a right answer, and various things are possible, but in many cases, particularly with patients with type 1 gastric neuroendocrine tumours, we tend to err towards doing less rather than doing more. But the occasional tumour does need more aggressive treatment. If you want to know more about this, we wrote a review in Alimentary Pharmacology and Therapeutics about it recently, which I would draw your attention to. And finally, just some thanks to my colleagues in the NET-MDT at Liverpool, some colleagues in the physiology department at the university who helped me with the biochemical analyses and the funding, as I've already mentioned. Thank you very much.